So, it's me again. And what we're going to do now is just sort of introduce you to why we wanted to get involved with academic medicine, why we set up the Academic Medicine Society, and why we spent a lot of time and effort trying to organise this thing. So my name is David Carroll, and I'm a third year post-intercalation. This is Nathan Cantley. So Nathan is an intercalated master's student after third year, and this is Jack Thompson, who's a fourth year. And you'll probably become quite familiar with us if you aren't already. And so about a year ago, last October, it was right before October, we went with the professors in medical school to chat to them about setting up an academic medicine society. And then we were told about this initiative from the Academy of Medical Sciences called the INSPIRE program. We had no idea what the INSPIRE program was. And ourselves and Professor Kennedy went over to London for the day, which was really great to get a day trip to London. And without knowing what to expect, we came home, I suppose, inspired to inspire others, which sounds incredibly cheesy, but I think it sounds cool. And so we came back and applied for a grant through the INSPIRE program, and thankfully we were successful, and we got a £10,000 grant from the Wellcome Trust and the Academy of Medical Sciences to put on things like this. The first thing is what you're at today, the Student Research Symposium. We've organised an SSC to give second year medical students an introduction into what academic medicine really is. And thirdly, we hope to introduce a mentoring scheme for medical students. And part of the reason why I think that's really important, I'll allude to later whenever I speak about my experience in the intercalated degree pathway. So yeah, we're here. We hope you have fun, enjoy free food, meet lots of new friends, and learn lots. And learning is the most important thing. And at the back of the room, you might have noticed already, we have the BMA and Biomed Central. So I think the lady from BMA has left, but she has left her stuff behind. So if you want any free pens or free stuff, or any information about careers, I think it's all down there. And Biomed Central is the second stand. And we invited Biomed Central for a number of reasons. Because this week is Open Access Week. And I'm not too sure if anyone knows what Open Access is, but if you come talk to me over coffee, I'll explain everything. And we, as sort of undergraduate students, think the only way to publish research is if it's openly available for everyone to read and reuse the results as they see fit. So Biomed Central is an open access publisher of 257 science, technology, and medicine journals. So Shane is somewhere down the back. He's waiting. So if you go down and speak to Shane, he'll tell you why open access to research is really important and really cool. He has some Gullivers, which is the open access turtle to give out, some free pens, and yeah, thank you, and we hope you have a great day. And first up, actually, I've nearly forgot my last two roles. We have a hashtag on Twitter, so it's hashtag QUVSRS13, so please tweet. I don't want to be the only one. And first off, we have Professor Alan Smyth, who's doing the keynote address. And since I didn't want to memorize the biography, I think I'll just read it out. So Professor Alan Smyth is Professor of Child Health at the University of Nottingham, an honorary consultant in paediatric respiratory medicine at the Nottingham University Hospitals NHS Trust. He is the director of the Nottingham Children and Young Persons Cystic Fibrosis Clinic, and he has a major research interest in novel ways of treating infection in cystic fibrosis and strategies to detect and minimise the adverse effects of treatment. He is the director of the NIHR Medicines for Children Research Network, East, and coordinating editor of the Cochrane Cystic Fibrosis and Genetic Disorders Group. This group has an interest in delayed publication of clinical trial results and the consequent bias in the evidence base when he's not working, and as you'll see in your programs, he's a keen cyclist. So I'd just like to invite Professor Smyth to come up to the podium, and thank you.
Thanks very much for that introduction, and I'd like to thank David and Jack and Nathan for the invitation to come and speak. And I think this is a fantastic symposium this afternoon, a very exciting program. And I think the link with the Inspire program and the Academy of Medical Sciences and the Wellcome Trust is a really great link to bring to Belfast. What I'm going to talk about, or attempt to cover, is why, how, where, when in clinical research. And really what I want to do is convey what enthuses me and excites me about clinical research, in the hope that some of it might excite you as well. I'm not going to go through in detail the various opportunities that there are for research at each stage of training, because I think that will be covered later on this afternoon. So I have to explain why I'm excited to be in Belfast. And I suppose that's because originally I'm a local boy, as you may have figured out from the accent. And I'm going to try a picture quiz with you. The questions are of varying difficulty. So here's the first one. I don't know how well that picture projects. This is actually from an article in the Ulster Medical Journal, and it shows a rather anonymous grey building in a Belfast street. Would anyone like to hazard a guess where that might be? Okay, well I said it was a really hard question. It happens to be the Malone Place Hospital, which I discovered when I was applying for a passport was formerly known as the Belfast Midnight Mission. And I discovered this little piece from the Ulster Medical Journal, which says, it's just telling the history of the institution, and it says, the story begins in 1860, when some Belfast ladies, being concerned about women and girls who frequented the public houses of Belfast, purchased 4 houses in Malone Place. The ladies went out at midnight and invited the women to come back to the Belfast Midnight Mission for the night. So in 1960, it ceased to be the Belfast Midnight Mission and became a GP maternity unit. And in 1962, I arrived in this building. So that's where I was born, so I am a local boy. Now, having said that, I could not find my way from the Titanic experience in the Titanic Quarter to Queens without getting hopelessly lost in the centre of Belfast, so I think my credentials may be a bit limited. So the second picture in the picture quiz is top left. Anyone know where this is?
Newcastle.
Newcastle. Anybody in the room from Newcastle? There must be someone. No one. Okay, well, no one's admitting it anyway. Well, I think this is the most beautiful place on earth, and that's where I grew up. And anybody recognize the crest, top right? Down High. Anybody from Down High here? Yes! So I feel very comfortable now. So our crest with its motto, Floreat Dunham, may down flourish, which really confuses the opposition, particularly when you shout things like up, down. So Newcastle, up, down, and Down High School. So that's my early biography, and that's my claim to be excited about being in Belfast. And I also have another motto, and this is my personal motto, Nil illegitimi carborundum. Anybody in the audience know this one? Any classic scholars? It means don't let the bastards grind you down. And whenever one of my PhDs or one of my research group fails to get a paper accepted by the ignoramuses of the journal, or fails to get their brilliant grant funded, I send them this 3-word email, which usually baffles them momentarily until they discover Google Translate. But and the message from that is that academic clinical medicine can be discouraging, and you need to harden yourself against discouragement. I've got a few conflicts of interest to declare. So I'm a children's doctor, I'm a pediatrician, so some of the examples I give you in this talk will come from my bedside experience as a pediatrician. These young people, this is taken from a mural at Nottingham Children's Hospital, and these young people have done their own mural, their self-portraits, as part of the wall decorations in the new Children's Hospital. So back to the original question, clinical research, why? This is a gargoyle which appears on the church at the top of our road in Nottinghamshire. And he has a wonderful kind of why me expression. But I want to try and address the why question. And I suppose I'd put it that why do clinical research is kind of, the answer is kind of the same as why do clinical medicine. So we do clinical medicine because we want to help poorly people get better, or we want to alleviate the burden of illness and allow people to experience better health, or put in a sort of cliche, we want to help people. And I do clinical research because I would like clinical practice to be better in some tiny way when I retire compared to what it was when I started. Because it makes me angry when I see patients who are harmed because of our ignorance of what constitutes best practice, or because of the hold-ups in getting research evidence into practice. And I suppose the other reason I do clinical research is because I'm incurably curious. And I think it's okay to be curious, and I think it's okay to say that's why you do research, though it's a bit unfashionable. But the starting point of clinical research should be with the patient. So I'm going to start with this young man, and his name is Jack. And when this photo was taken, he was about 5 years old. And he suffers from cystic fibrosis. So if this worked example is going to work at all, I need to tell you a little bit about cystic fibrosis. So I'm going to go off on that slight tangent for a few moments so that you can now understand the clinical research I'm talking about. So cystic fibrosis, or CF, is an autosomal recessive disorder. It's the commonest autosomal recessive disorder that is life-limiting amongst Caucasians. And the carrier frequency is about 1 in 25 in the population. The birth incidence is about 1 in 2,500. And the gene for CF was first identified shortly after I qualified in medicine by Lachi Choi and Francis Collins. And it was published in this edition of Science in 1989. And on the front cover was a child with cystic fibrosis, Danny Bisset, and this is Danny Bisset in his late 20s. And that illustrates the fact that the discovery of the CF gene has been accompanied by steady developments in CF care, leading to the most recent development, which is genome-specific, genetic-specific therapy. So in other words, the knowledge which we gained from discovering the CF gene has led to a drug which is targeted at a specific gene mutation and is now a therapy that I use day to day in the clinic. But that, as you can see, took a considerable length of time, well over 20 years, to go from basic discovery into clinical practice. Genes on chromosome 7, and it codes for a protein called the cystic fibrosis transmembrane conductance regulator. And how, you might ask, does that cause disease? Well, this CFTR protein is a chloride channel, and it is located on the apical membrane of respiratory epithelial cells. And probably the best way to understand how this defective gene, which leads to a defective protein, leads to disease, is to look at a video. So I'm going to play this now for you, and I'll try and talk to it as it goes. So here we go. So here we have the mucociliary escalator, the green mucus, floating on a raft and being wafted up the airway with impurities and bacteria by the rhythmic movement of the cilia. And these cilia only work when they're bathed in an aqueous layer. So they're bathed in water, and the mucus floats on top of that. And the water stays in there because there's salt. And the salt, or at least a component of the salt, the chloride, moves through CFTR, the chloride channel. And the salt draws water in osmotically. It maintains the thickness of that periciliary layer, and it allows the mucus to float on top like a raft and be wafted up the airway with impurities and bacteria. We now look what happens in CF. The periciliary layer is diminished, so this layer is not as thick as it should be. The mucus impacts on the cilia, and the cilia don't work properly, so you get stasis. And where you have stasis, you get opportunistic infection and mucus plugging. And the reason this occurs is because the chloride channel, if it ever gets to the cell membrane, is not allowing chloride ions through. The salt content of that periciliary layer is not enough, and so there's not enough water there, and the mucus impacts on the cilia. So that's what we understand as the biochemical and physiological basis of CF lung disease. And what does this do? What are the implications of this? Well, it sets up a vicious cycle of infection. So I said the opportunist organisms bundle into this static mucus layer and cause infection. This leads to inflammation. And much of the lung damage in people with CF is not down to the virulence factors produced by a pathogen, but rather it's due to the host immune system working in a kind of unregulated fashion. It's due to neutrophils releasing their proteases and damaging the lungs, and that damage looks like this. So this is a CT scan, which I can show you in a bigger picture. And this is from a 10-year-old girl with cystic fibrosis. You can see here the airways. And what you should be seeing are airways which taper like the branches of a tree to the most delicate twigs at the periphery. But looking here, these are not delicate twigs at all. These are very widened airway, and they're full of infected mucus. You also get mucus plugging, and what's happened here at the lower part of the left lung is that a plug has impacted in the left lower lobe bronchus and has led to complete collapse of basically a third of the left lung. So this is not functional, and it's a reservoir of infection that spreads elsewhere. You can see these mucus plugs. Here's one blocking an ET tube that we'd use to perform a bronchoscopy. And you can see that they're large, thick, and adherent. The good news is that this little girl is shown here in the picture. She's presenting a bouquet to the Queen. About 9 months after that CT scan was taken, she had a double lung transplant. She has gone on to take her GCSEs, and she's currently studying for A-levels. So although the lungs of CF patients are ravaged by disease, there is, for a small proportion of patients, the option of transplantation, which, at least for a short period, produces a fantastic outcome in some. So I mentioned infection, and as you heard in the intro, I'm really interested in infection. I'm thinking how we could treat it better. But you need to know a little bit about what happens in CF so that the rest of what I'm going to say makes sense. So we're particularly concerned about this organism here, Pseudomonas aeruginosa. This is the organism that CF patients and their parents often fear. And the sad truth is that many patients acquire a chronic infection which cannot be treated to the point of eradication. And what happens is this organism lives in the environment. It likes damp places like sink drains, for example. It finds its way into the CF airway, and when it first arrives, it's in what's called a planktonic form. So it's a free-swimming organism. But very quickly it forms colonies, and ultimately a very complex colony called a biofilm. And within the biofilm, you've got semi-dormant organisms, and they're surrounded by an exopolysaccharide matrix. And it's easy, looking at this section of a biofilm, to imagine how it's very difficult for antibiotics to penetrate in there by diffusion, and similarly, very difficult for the host phagocytes to get anywhere near these organisms. So treating infection in CF patients who have Pseudomonas effectively is very difficult. And I suppose this explains why CF clinicians, and particularly pediatricians, are obsessed with Pseudomonas. If you come to the hospital, if you're a CF patient, you come to our hospital and you stand still long enough, we will take a respiratory sample from you, and we'll go off and look at that for Pseudomonas and other organisms. And if we find Pseudomonas, we hit it very hard, because there's a window of opportunity before we go from the planktonic stage to the biofilm stage where the organism is treatable. And we want to hit it hard with antibiotics in that window. And we usually use a combination of nebulized antibiotics, so coming at it from this angle, combined with systemic antibiotics such as oral ciprofloxacin from this angle. So back to Jack. So as I say, this picture was taken when he was about 5, but when he was 4 months old, Jack developed a respiratory illness, which we thought was bronchiolitis. Very common in children of that age, a bit more severe if you've got CF. But he also had some respiratory samples taken looking for bacterial infection, and we found Pseudomonas. So he was looked after by one of my colleagues in one of our shared care hospitals, and my colleague had a dilemma, how to treat this Pseudomonas. As I mentioned, one option is oral medication and nebulized antibiotics. And the problem with that is if you've got a 4-month-old baby who's already breathing very quickly, who may need some oxygen because of the bronchiolitis, then nebulizing an antibiotic is not a great option, because not all of that antibiotic is going to get into the airway. So what my colleague chose to do was to give intravenous antibiotics. And our practice is to use 2. As I mentioned, this is a resistant organism. So she used a combination of a cephalosporin, captazidine, and an aminoglycoside, an antibiotic which you may be familiar with called gentamicin. It's widely used. And he had his course of 2 weeks treatment. 2 weeks sounds like a long time. It is, but it's standard for CF patients with lung infections. And he went home after 2 weeks. From the respiratory point of view, very well. But shortly after that, he started vomiting. He was unwell, and he came back to hospital. And he had an initial workup which showed that he had acute kidney injury. His creatinine was around about 500. And in fact, he required dialysis for 5 days and was really quite ill. On follow-up, some months later, he had a normal renal function as far as we could see, a normal blood pressure, so things seemed to have worked out well. But some years later, when we could do some more detailed testing, and particularly when we could test his hearing, we found that he had high-tone sensory neural hearing loss, which is another side effect of gentamicin treatment, and indeed can be any aminoglycoside. So here was a little boy of 4 months who had already suffered 2 serious complications, one life-threatening and one leading to permanent disability, as a result of the treatment that we gave him. And I guess this was, for me, a turning point where I was asking the question, could we do this a little better? Is there some way we can give this essential treatment which isn't going to cause harm? So I'd like to introduce you to something that I'd call the virtuous cycle of evidence. And this is really going from that starting point where you're at the bedside, you've got this clinical problem, you're thinking, could we do this better? And you're ending up with improved clinical practice. And I want to take you through some of the steps in between. And I guess the first thing you have to do is formulate a testable hypothesis. And really, the testable hypothesis has to be biologically plausible. There has to be a well thought through reason why a different approach to antibiotic dosing, in this case, could lead to a better outcome. So this led me to think through this problem. Now, how could we somehow protect the kidneys from the effect of aminoglycosides? Well, if you look at the physiology of this, what happens with aminoglycoside antibiotics is the body gets rid of them by filtering them in the glomerulus. But then, strangely, it reabsorbs some of the aminoglycoside from the tubular fluid into the proximal tubular cells here. And it is that reabsorbed aminoglycoside that does the damage within the cell. So if there were some way we could block that tubular reabsorption, then we might have a better outcome for our patients in terms of reduced toxicity. And one way you might do that is by saturating the uptake. So if you work out how much aminoglycoside your patient needs for that day, at the time Jack was treated, traditionally what you did is you divided that up, you took that total amount and divided it into 3 doses and give it hourly. And that was really because of custom and practice. We did that because that's what we always did. But there's another way of doing it which had been practiced in other fields. So the oncologists, for example, who are treating gram-negative infections in immunosuppressed patients all the time, were already starting to give a once daily dose. And the idea with that is that it saturates tubular uptake. So most of the aminoglycoside dose is actually passed in the urine, and very little is reabsorbed. And what you want to aim for is this once daily dosing where you get a very high peak of aminoglycoside in the plasma, and then it drops down to a very low level. And that's reflected by a very high amount initially at the glomerulus, which very rapidly tails off. So the idea is to saturate tubular reabsorption. So here we are, we have a testable hypothesis. Should we give the total daily dose once, or should we divide it into 3 or more doses? So once you've got your testable hypothesis, the key thing is to figure out whether anybody's done this before, because if they have, you already have your answer, potentially, and there's no point in going off and doing clinical trials or whatever else you might wish to do. So you have to start with a literature search, and we combine that with a systematic review. And I'm going to tell you a little bit about systematic reviews. I know that we have some Cochrane enthusiasts in the audience, and I'm a self-declared Cochrane enthusiast myself. But I'm going to walk you through what this involves and why it's important. So you've got to search the literature to make sure it hasn't been done before. And that means searching the literature without any preconceptions. So you need to look at a number of databases, PubMed, Medline. The Cochrane collaboration maintains its own database of clinical trials. And you shouldn't restrict it to one language, because it may be that important work's been published in Chinese, for example. And you shouldn't restrict it to the published literature. So in some cases, you have to go after these papers. You need to write to pharmaceutical companies that manufacture drugs and ask them for data which they hold in their archives. You may need to contact the authors of work that's only been published in abstract form because you want the whole thing. And the holy grail is to get individual patient data, and we've been lucky to get that in some of our reviews. But the idea then is that you've got all this information and you publish a protocol on the web for everyone to see. We're interested in this question. Can we give the amino glycoside antibiotics more safely if we give them once a day? And here's what we're going to do. We're going to search the literature. We're going to look at these outcome measures such as improvement in lung function and the effect on renal function. And we aim to then publish this as a completed review. So if somebody else is working in the field, they can look at your protocol and they can see what you're doing. I guess the other thing to bear in mind is that a Cochrane review is for life. So we all know that the medical literature changes week to week. So a review that reaches an uncertain conclusion today, in a year's time, the trial may have been done that clinches it. So when you take those data and you add them to your existing data and you do a meta-analysis, you may have your answer. So you do need to be scanning the literature and regularly updating your review. And our rule in our Cochrane group is that we do this every 2 years, unless it's a really happening area, in which case we do it every year. So the Cochrane collaboration has just celebrated its 20th anniversary. It's effectively an international network of volunteers. So people like yourselves, junior doctors, senior doctors, who are interested in a particular clinical question, and they've made it their own, and they probably know more about it than anybody else in the world. And they've conscientiously gone out and got that literature and combined it to get the best answer. And it's not just a head count of trials, this one found benefit, this one didn't. It's actually combining the data to get the best answer for each outcome. This is our Cochrane group, having our annual meeting in Liverpool. We're cystic fibrosis and genetic disorders. So we cover CF, lots of us are CF enthusiasts, but we also cover things like sickle cell, thalassemia, coagulation disorders, and we're interested in inborn errors of metabolism, and that's an exciting area at the minute because there are new enzyme therapies that are available for patients that are being evaluated. If you'd like to take a look at what we do, I've given the link here, and also I'd recommend you go and have a look at the Cochrane Library as well, and just browse through that. It's done by topics, and if you're interested in infection, go and look at that. If you're interested in oncology, you can look at those, pregnancy and childbirth. Each one is linked under a theme. So in Jack's case, we went ahead and did a systematic review. And we found that there were only 3 trials comparing once with multiple daily doses of aminoglycosides, and we found that only 2 of those were published, and the total literature was about 170 patients. And we were unable to reach a robust conclusion. So what we said was, we don't know the answer to this question, we need to do a clinical trial. And thankfully, that conclusion convinced the patient organisation that funds much research in CF, the Cystic Fibrosis Trust, to fund us to do that clinical trial. And to do the systematic review is an incredibly powerful lever to get funding to do research. If you can say, look, we have looked everywhere, and the answer to this question is not known, and this is an important question, then it is much easier for funders to back you. And we did this trial. This is a trial called the TOPIC trial. At the time, it was the largest clinical trial in CF ever to be conducted in the UK, and we very simply compared a once-daily regimen with a 3 times daily regimen of tobramycin, and we looked at the improvement that the patient experienced in their clinical state based on their symptoms and their lung function. We looked at their hearing, and we looked at their renal function as well. And what we found was that with the once-daily treatment, they were equally effective. Patients got better just as well with a once-daily dose as they did 3 times daily, but their renal function was better in the once-daily group. And this allowed us to take the data and combine it with the other 3 studies that had been done and get some really robust conclusions. So now we had a systematic review that showed clear evidence, as opposed to the previous situation in 2000 where we had insufficient evidence. By 2006, 2007, we had clear evidence of what we should be doing. But the fact is that if you're struggling in the middle of the night with how to manage a patient and you're really not sure, you probably don't reach for the Lancet, and you probably don't reach for the Cochrane Library. You might reach for guidelines. So if we want to change the way people practice, we need to get those data into guidelines. So we had our robust conclusion: once-daily manic glycoside treatment for pulmonary exacerbations should be adopted, and we had to go ahead and have that incorporated into a clinical guideline if we hope to change practice. And just about that time, there were 2 guidelines in preparation. One from the UK, the UK CF Trust Antibiotic Guidelines, and the other from the US. And I'm pleased to say that the recommendation that we give once-daily manic glycosides has been incorporated into both of these guidelines. And interestingly, in the US guidelines, there were only 5 recommendations that could be made about how to treat a chest infection in CF based on good evidence. Of those, one was to carry on all the treatment that you were doing previously. 2 other recommendations were to not do certain treatments that were known to be harmful, and one of the remaining recommendations was a positive one, which was to give once-daily manic glycosides. But it's all very well getting into the guidelines. Does anybody pay any attention? Does practice change? And we thought we'd look at this with a survey. So way back in 2002, we wanted to know what current practice was, and we found that only 17% of UK CF centres were using a once-daily regimen. This year, after we did our trial and we published the Cochrane Review and we incorporated that into guidelines, that figure had gone up to 86%. And a similar pattern we saw in Australia, where they tend to use UK guidelines, where the figures were an increase from 54% to 88%. And when we asked the CF centres, well, why did you change? Of the 22 who changed in the last 5 years, 20 said it was because of our trial, or indeed because of the systematic review. So that's the virtuous cycle. You start off at the bedside with a clinical problem, and if you work through the steps, you can come up with improved clinical practice. And I guess the acid test really about whether that matters is whether the health of your patients improves. So we were really interested to know whether there were fewer patients with acute kidney injury with CF in 2013 compared to what there were in 2000. And for that, you need a registry. And in the UK, we're really lucky. We've got the UK CF Trust registry, where clinicians up and down the country are entering data on their patients, which they do at least once a year. Some of them do it more often than that. And there's a key set of data which is entered on the registry, and this is enormously powerful for all kinds of things. Benchmarking care, talking to commissioners, looking at research questions like this. So the registry looks something like this, and I asked specifically for data on acute kidney injury in CF patients year on year. And I have to say the result was not encouraging. So this is what we got. Bumping along at a few cases a year up until about 2009, when the incidence went up like a rocket. And if you've just spent the last decade trying to improve care and improve the kidney health of your patients, this was a bit of a disappointment. And we scratched our heads trying to explain these findings. And I think why this has occurred is probably because of the way the question is asked. So you do one of these reviews for your CF patients, and you're asked about all the complications that they've had in the last year. And a long list appears, such as liver disease, arthritis, diabetes, and so on. But one of those is renal failure requiring dialysis. And what I think is happening here is that clinicians see this question and think, yeah, we've got a patient who's had kidney problems, and they tick the box. And next year they see the question again and say, yeah, we have that patient who has kidney problems, and they tick the box again. So what you're getting here, I think, is cumulative prevalence and not annual incidence. But if you want to show that what you do is changing anything at all, you need annual incidence. So what we're going to do is go back and we're going to look at the way this question is asked on the registry. We're going to have an enhancement, and hopefully the data over the next 5 years will give us something reliable by which we can judge this outcome. So that's one thing in the toolkit to make aminoglycoside therapy safer. But is there anything else that we could be doing? And what are the appropriate research methodologies for investigating this? So one of the things I'd encourage you to think about at your stage, and indeed at any stage, is that if you are involved in managing a patient where you think there is a generic lesson to be learned, go ahead and report that and describe what you've learned from it, because others may benefit. And that's exactly what we did here with Jack's case. We published his case with a number of others that have been referred in to my colleagues who are the renal physicians. So we had a case series, and then we thought, well, okay, this has come out of the blue. We've never seen CF patients with kidney problems before. I wonder if other people are experiencing the same problem. So we did a national survey, and we wrote to CF centres all around the country, and we said, look, have you ever been involved in managing a patient with CF who's developed acute kidney injury? And from this survey, we were able to identify 55 cases. We had to do, as you would expect from that question, we had to do a little bit of sifting out, because undoubtedly the way we asked the question meant that there was duplicate reporting, but we'd rather have that than miss patients. And we were able to identify unique patients rather than the same patient reported twice. We were able to look at the notes to verify acute kidney injury in about 24 of those 55. And the reason for that is it requires consent to look at the notes, and there was quite a bureaucratic procedure, so we didn't manage to do that in everyone. But that came up with an incidence of acute kidney injury of somewhere between 4.5 and 10.5 cases per 10,000 CF patients per year, and there are about 9,000 CF patients in the UK. So this is about the annual incidence of acute kidney injury. The 4.6 are the verified cases, the 10.5 are the reported cases. Now, that may not seem that important, but actually, in children, the incidence of acute kidney injury in CF is 100 times the general population of children. And CF doesn't really affect your kidneys. So this is something we're doing, and it's quite a dramatic effect. This is iatrogenic harm. And these weren't trivial cases. Over half required dialysis, and the vast majority had received an aminoglycoside. So very much this is pointing the finger at the class of antibiotics that we were concerned about. Not only that, well over 2/3 of cases were associated with one aminoglycoside, gentamicin, and only about 1/3 of centres were using this aminoglycoside. So this pointed the finger of suspicion at gentamicin. But I guess association doesn't prove causation, so we really wanted to see if we could strengthen the case and whether we could make a firm recommendation to colleagues. Now, making a recommendation to colleagues along the lines of don't use aminoglycoside antibiotics is not terribly helpful, because, as I mentioned, Pseudomonas is a resistant organism, and it stays in the lungs of our patients for a very, very long time and becomes progressively more resistant. There are only 3 classes of antibiotics, really, that are effective against Pseudomonas. So to take one of those classes out at the outset because of safety issues isn't really an option. So what we were talking about is refining the way you give these antibiotics so that we could enhance patient safety. And it would be very helpful if, rather than say don't use aminoglycoside, we could say don't use gentamicin. And what we found, what we did then from the national survey was we went ahead and did a case control study. And we took each of those 24 cases where we verified the acute kidney injury, and we assigned 2 controls per case. And the controls were matched, so they were roughly the same age as the index cases and the same sex. And what we found was that acute kidney injury was strongly associated with aminoglycoside use in the preceding week.
To our next session, which is going to be chaired by Professor McMullen, who is Head of Undergraduate Careers here within the school. So, Professor.